Thank you, Cindy. Well, I'm delighted to be here and just really excited to see all the neat things that you're doing here in Texas. I was here with CFHA, when was that? A few years ago, and was able to meet with a number of clinicians. So, despite I know that it can be a very challenging funding environment, it's really neat to see pockets of just real innovation and integration just emerging across the state. So what I'm going to do today is just share with you our story. I'm with Cherokee Health Systems. We are a federally qualified healthcare center and a community mental health center, and we call ourselves the hybrid safety net. We are in 14 counties in East Tennessee and expanding quite a bit. We have a saying, Cherokee goes where the grass is browner, and there's a lot of brown grass in Tennessee. And so we've been expanding quite a bit. So in fact, on Monday we open a new clinic near Oak Ridge. So Oak Ridge is like a nuclear facility. If anybody knows the bombs from Hiroshima, they were built there. That's the claim to fame. Which is kind of a very interesting place to go to if you're ever in that neck of the woods. So what I'm going to do is just share with you our story, how integration has kind of developed and shaped our model of care, and talk about the frame and context for the role of psychologists. And I think really the best way to do that is really just talk about in general what is involved in implementing this clinical model and the workforce, and how do you make it work financially? Because rather than thinking about how do you morph a system to fit psychologists, I think it's important for psychologists to say what's an integrated system and what are the ways that this profession can contribute. And I think it's beyond, frankly, just providing direct clinical care. I think there are lots of options to do that, and certainly we can see that within our organization. In our leadership, our CEO is a psychologist. I'm now Chief Clinical Officer. I'm a psychologist, and we have psychologists in a number of leadership positions. So as you can see in our mission, integration is a core part. Primary care behavioral health is really a key foundation and philosophical approach to our care model. And whenever we come to a fork in the road or we're trying to decide what to do, we always go back to our mission. And I find it helpful to highlight this and start with this, because what you see is, for us, integration is not a program. It's not like a subset. It's not just, we do this on the side or for this one clinic, but it just really is kind of the way we provide care. That's a little bit about our corporate profile. As I mentioned, we have been very expansion-minded, and so now we are $50 million healthcare service company with almost 60,000 unduplicated patients and for about 450,000 patient services per year. And if you look at our number of employees, we have a lot of psychologists for a community health center. We try to keep as many psychologists as we do primary care providers. We really try to build an integrated team and a multidisciplinary team so we can provide just a broad spectrum of services. So this just sets the ground so you know kind of where we come from. In terms of strategic emphasis, again, integration is critical for us. We don't open now a behavioral health clinic without primary care or primary care without behavioral health. It's just the way we provide care. Outreach to underserved populations really is our mission. As a federally qualified health center, community mental health center, we see anyone who walks through our door, regardless of ability to pay. So for many people, we are the choice for their care, and for many people, we're the only choice, the only people. And there are counties where the only place to go is a Cherokee Health Systems clinic, and I think that's just very critical when you look at the data in terms of the underserved and unserved across the country, as we really need to be thinking about not just who is in our clinics and who's at our doorsteps, but who isn't and who needs outreach to get care. School-based health services, I'm really excited to hear that we're getting more and more school-based services. This has been an explosion in our communities, and in fact now we have 20 23, 24 school-based, either we do telemedicine to the clinics or we have a school-based clinic. And it's been a real hit doing telemedicine into the schools, particularly our rural schools where we have our providers, at a center, and we're beaming out because the kids are already there. We're able to provide acute medical care as needed. And for parents who live in the mountains or work in factories who can't take a day to drive 3 or 4 hours to take their child to the doctor for an ear infection, it's a huge thing for them to be able to be seen in the clinic and get the service they need through electronic health records. We can send the prescription to the pharmacy, get all that stuff done by the time they pick up the child. So that's been a really neat way for us to again, bring the care where it's needed the most. The safety net preservation I mentioned, and telehealth is a big thing for us. Tennessee we're a very wide state. Like Texas is just big. Like, anywhere to anywhere in Texas. It's always interesting when I lived in Texas just for a couple of years, 15 years or so ago, and you would talk to people and they would say, it's not far, you can just go there for dinner, it's not far, and then you find out it's an hour and a half, and an hour and a half in Texas is nothing, and in Knoxville, you say it's 15 minutes away, oh, it's too far. We're not going to do that. So what we have done, but we are a wide state, and so what we've done is set up, and particularly because of mountains, travel can be very, very difficult. So we have set up telemedicine quite a bit. We have it for primary care. We have it for psychiatry. We do it for pharmacy. We had to get a law passed just to do it for pharmacy because the retail pharmacies initially didn't like that idea, and we said, trust us, you're not competing with us. There's nobody where we're going. And we also have psychologists who do tele-BHC, if you will. We have a psychologist in Miami who speaks 4 different languages and beams into our migrant health center. And that's been a great way of just, again, providing access to care. And then I'm going to be talking about this move toward value-based contracting. So this end point is important. Why am I talking about value-based contracting when we're talking about psychology training? Because when I went through graduate school, nobody talked to me about money. Nobody talked to me about business management, and Cindy and I were talking about this last night. And now in today's world, you have to speak that language, and more psychologists are coming into leadership positions, and you have to think like a business person. And so while you want to provide ideal quality of care, ideal training, you have to make it work from a fiscal perspective. So a lot of the training has happened, for many of us, boots on the ground. Dr. Blunt is the same way. I mean, I'm sure he's doing much more business now than he ever thought he would, while remaining true. But these are some of the competencies and some of the ways we need to be thinking. So graduate students, sorry, but start thinking about this right now. Nobody talked to me about it, so I'm going to talk to you about it. Okay. So let's start with our clinical model, because again, our model of care drives everything that we do, and this has been very critical for us. We obviously did not follow the money, because if you follow the money, you can end up in a very meandering path. And had we done that, we would have not moved to integration, because when Cherokee first started doing this in 1984, boy, did we lose a lot of money. So, we went at it and we have to do the right thing, and then we will make it work on the financial side. So that's the first thing I would say is if you just do something for the money, I don't think that you're going to get the same level of comprehensive quality of care as if you just focused on that at the get-go and then look at kind of the financing of it and see how you can make it work. So in terms of our model of care, our goal is to improve the quality of general primary care. That's going to be critical for us. The reason I put these goals on here is for all of you who are thinking about implementing a program, think about how easy it is to get lost in the weeds. So how many times have we all sat in a meeting where you're implementing anything and you're realizing you're talking about A, right? So you're like, I'm going to talk, how are we going to get A to happen? And then someone brings up, well, to do that, we have to do B. And then to do that, we have to do C. And then pretty soon, you're talking about something completely different, and everyone's, boinging back together, back and forth about, something that's about 15 degrees removed from the original goal. So I always say, write down your goals. What do you want to have happen? Because whenever you get lost and whenever you find yourself in those weeds where you just feel like you want to throw a brick at somebody or your own head, like, why are we talking, let's go back to our goals, because that's what we do. And so we can stop and say, wait a minute, what are we trying to accomplish here? We want to improve the quality of primary care. We know there is no good primary care without good behavioral health care embedded in it. You just can't do it. Octavio talked about why. Dr. Sandy's going to talk about why you just can't do it. So we have to do that. We need to improve access to behavioral health expertise. Primary care providers, God bless them, if they actually did everything they were supposed to do, like with all the prevention, everything they're supposed to do, it would add another 10 to 14 hours to their day. And I don't know about any of the primary care docs or providers but you can't operate in negative time when you're already working 16-hour days. So we need to give access to that behavioral health expertise. We need to improve communication and co-management. I love that slide by the FAM study in terms of how many people you need to coordinate with. I mean, this is crazy. Our patients are going here, there, everywhere, and then you'll ask them, what medication did this provider put you on? You can't get them on the line. They're saying, well, it's a blue pill, it's oval. And, I got it at, Blue's Pharmacy. That doesn't tell you, although that can have tremendous impact on that person's health status. So we want to improve that communication, and certainly we want to meet patients where they show up. Every day, people show up in primary care with significant behavioral health needs, and most of the people, I still see patients, most of the people I see have never seen a behavioral health provider ever. People walking around with tremendous suffering. I saw a woman, she had been raped multiple times as a teenager, and now she's like, I think 53, and still having nightmares. She never went to anybody, You just would not go. She lives in a rural area. She drives a couple of hours to see us. And so what we want to do is, she's showing up, and basically I got involved because she had gone so long without having a GYN exam. She wouldn't let anybody do it. No way. Now, she had a number of symptoms, and she couldn't just ignore that. So this is how it came up. She's showing up to primary care. Now, can we provide good primary care for her without bringing in a behaviorist? You can't do it. So we were able to really work with her just to get her to have a pap smear and to have, like, a GYN exam. The prevention and at-risk intervention piece is something that's really important for us, I think, in behavioral health to get involved with, because we learn all these great theories and strategies for behavior change and how to make good health behavior change. And then when we go into practice, we tend to focus primarily on pathology, right? The sickest folks come to us. However, I feel like psychology and behavioral health has so much to offer in terms of wellness and adaptive functioning and resiliency. It's just the specialty mental health sector is not set up for that. It's only set up to address pathology issues. So it's so cool for us to be able to talk with people about how to be healthy, how to cope with stress, how to manage, for our kids. We have our psychologists as part of our well child exams in our pediatric clinics. And then we can talk with them about how to manage a temper tantrum. Well, we would much rather teach someone how to manage a temper tantrum and how to improve a child's sleep and how you set a structure to their day when they're 3 than to see them with a diagnosis of disruptive behavior disorder, ODD, or AD, give them medicine at age 6 or 7. Okay, that is something that's critical for us. Now, of course, that doesn't, one gets paid for, one doesn't, right? But it's really, really neat to be able to bring the expertise of psychology into a broader spectrum of healthcare issues, not just people who have very severe mental illness, because as Octavio showed us, so much of this shows up early. It's just not caught early, so it can take almost a decade to get the diagnosis. What about those 10 years or even before the symptoms started emerging. We need to be there, because that's where we're going to have our impact. And then certainly want to coordinate with specialty mental health. Specialty mental health and the need for it is not going away. We need it. We just don't have enough of it. And now what we need to do is bring some of that to the primary care setting. So, and I would just urge you, wherever you are, and if you're thinking about integration, write down, these are just our goals. Write down what the goals are for you. What is your end game? Because anytime you get lost, you can just go back to that. Go back and say, now, what are we trying to do? We want to improve access, improve quality of care, you name it, but just write it down. It also helps to have everybody on the same page. What are we trying to do here? So all of you in the audience know you're psychologists. You write down your goal. What are your steps? Where do you be? It's basically doing what you would do with your patients with your own program. So let me just give you a brief overview of our model of care, how it's evolved over time. We didn't start out this way. We started out, in a more co-located model, and then we became more collaborative, until we moved to a blended care team. So for us, our psychologists, we call them behavioral health consultants. You can call them whatever. I mean, I think the name is less important. What's important are the competencies and functions. But they are all part of that team. We have a shared support staff, shared space, and then a shared clinical flow. So when someone checks in, they'll check in, it's the same front desk staff person, it's the same clinical record, which is fascinating to me that it's such a big deal for some people that you would have a shared clinical record. Well, of course you would have a shared clinical record. You wouldn't take someone's cardiovascular health and keep that in a completely separate record and say, you can see everything else about anything except for the cardiovascular system. We have to have a wall there. And you have to get a consent, a release of information. It doesn't make sense when you look at all the data in terms of behavioral health, mental health status, and its impact on other physical health symptoms. You need to know. You need to know in order to provide good care. So what we have then is when you bring everybody together in a team, just think about proximity breeds familiarity, right? So think about the people who you were friends with growing up. Who are you friends with? You're friends with people who live next to you, who you went to school with, who you went to church with, and so it's the same. So when you put just physically people in the same space and you give them a shared treatment plan and the same patients and a same record, you're going to just see increased collaboration and communication. And then certainly we build our reimbursement mechanisms to support that model. So what does that mean in terms of the behavioral health provider? What does it mean in terms of integrating this into the primary care medical practice? Number one, then the BHC panel, and I'm just going to use the word BHC, is the primary care panel. Now this can be very different from the way people think about traditional psychological practice. So the clinic that I work in sees 19,000 primary care patients a year. Guess what's my clinical panel? Who's on my list? All of those primary care patients. 19,000 patients, and that's for every one of our BHCs, and that's certainly where staffing comes into play, but you have to think, if it's a primary care patient, it's my patient, and that's very different from specialty mental health, where the people who are on my treatment plan list or who've been actively seen in the last 6 months, and in some places it's like 50 people, 75 people, 150 people, whatever it is, but it's nowhere near the primary care panel. You have to think like a primary care provider. Now, does that mean you see everybody every week for an hour? Well, you physically can't do that, can you? It just means that you are responsible for their health care, and so that's what, if that's the team's responsibility, you're on the team, that's your responsibility. So that also means care across the lifespan. Family practice is, we say cradle to grave, and that's what we do, cradle to grave, unless it's like a pediatric or specialty practice. That means, for me, one of the neatest things is people cycle through primary care for all kinds of things. They may have, bronchitis, or maybe they have some chronic health problems, or they come in for a flu shot. What that means for me as a psychologist is there are multiple points of access throughout that person's care and throughout their lifespan. And so, you know, it's very interesting for me. I may see someone for a few sessions for maybe anxiety management, and then I may not see them for a couple of years, but then I get a call saying, oh, you know, my mother died, or so-and-so died. Or I may pass them in the lab waiting area, and this is, you know, we have a waiting area and we're all in the same place, and they'll say, ooh, I need to see you, because, you know, I lost my job, or I started drinking again, or whatever. And then that access is same day, and in fact, point of care access. So in specialty mental health, very much you think of opening a case and closing a case. Primary care providers don't do that, right? Your primary care provider does not close your case out, and then if you have to, you know, you have to call and make an appointment, you know, you don't have to wait 3 months to get a new intake appointment, you know, if you haven't seen them in a while. So we have to think of it in terms of this primary care population-based way, but that also drives the kind of care you can provide across the lifespan. So I have to say, what a gift it has been for me to be able to experience and have that shared experience of our population and patient panel as they face different challenges in their life. They know that we're there for them. So I've got folks, you know, I may have been seeing them when they were teenagers, and then you see them again, and they're 20, and you may see them again when they're older. And I think that's one of the cool things about family practice and pediatrics, and that's one of the cool things about being in that setting. And I also like to hear when people are doing well, which we don't get to do very often in specialty mental health. But sometimes when a patient will come in just for a follow-up in primary care, they'll say, I just want to let you know I'm doing really well. And, you know, that's a great feeling. That also then means when you have this kind of approach is the decision-making has to happen with limited information. So, okay, this is my soapbox a little bit. You have to recognize that in primary care providers have to operate with the information they have at hand. And first of all, they can take a very good history. So one of the best things about being part of a team is you get to have access to the medical record. As a behaviorist, can you imagine before going to your intake, having a very rich source of information that you can move from and you can you know, use as a resource for yourself? So, you know, before we do anything, I always say your assessment starts by reviewing the medical chart, and then you can go in and have kind of your own assessment. But we don't have much time because in primary care, things move at a fast pace. And remember, our goal is going to be very focused. And so one of the challenges for our neuropsychologists coming out is they don't get to do an hour-and-a-half clinical interview in a full battery. You know, you don't get to do the, you know, MMPI and Rorschach and all this. And even then, they have such a hard time giving feedback in terms of what's my working diagnosis, you know. So I think what's very important is understanding with limited information, with the information that you have from your functional assessment and the medical chart, what can you do for this team and what can you do for this patient that would help them? Now, does it mean that it's not psychotherapy, and it's certainly not just doing psychotherapy but shorter. So if you think about, oh, I'm going to be doing this, it just means I'm going to, you know, take what I usually do in specialty mental health and just do it shorter, then you're really, you know, you're really selling yourself short as well as the patient short. It's a qualitatively different type of experience and type of intervention. And this can be really challenging for people in the beginning. But when you think about going to the primary care provider, if you go in and you have an infection, they don't say, you know, come back in a week and I'll give you an antibiotic. Or come back in 2 weeks and I'll give you your antibiotic, or I need to do more and more tests. It's like, no, I can give you an antibiotic now. So this is trying to decide what can I do to help improve, again, functional status and quality of life. What kind of intervention can I do embedded in, you know, my time with this person? And remember, that's not your only contact. You're going to see them as needed the way a primary care provider will see them. If you're really ill and the primary care provider needs to see you back sooner, they'll see you back sooner. Or they may say, I'll see you back, you know, call me if there are any concerns. So that is really kind of that frame, and that can be a little bit hard when we're used to having, you know, so much information. And I always ask folks, you know, sometimes more information is just more information. Are you going to get anything that would change your intervention plan? That's really the critical question. And certainly the way we document is going to be very different because everybody's reading this chart. I always think it's interesting, you know, when I was in training, I wrote these I was trained, boys, sometimes 6-page process notes, you know, and they were beautiful. They were so nice, but nobody read those. And actually the thing is here, my supervisor read them, but I think that was the only person who read them. But we can say there's so much we could put, but just because you can put it doesn't mean you have to put it. So you have to think, this documentation is not your personal process note. You know, I was trained, you have your process notes and you have your progress notes. I don't know if anybody else was trained with that. This is not your note. This is a documentation of the clinical service provided to that person. That's that person's note. You know, one of the things Sandy does that I love is he goes over his notes, what he writes with the patient. That belongs to the patient. And so I think that's a real shift in mindset for us, and recognize that what we want to do is just have a clinical record of what we did as part of that integrated chart. And that can often be a shift for us. And then certainly what this means as we have to respect treatment planning has to happen across the board. Some of the best information I've ever gotten about patients is from nurses and from the front desk staff, because the front desk staff are watching our patients in the waiting room. They know, they handle the calls. So this is a real shift for us in terms of the medical culture. And I have this slide. This is from our OBGYN clinic. And again, it basically just shows, I don't know if you can read it, but blue is for BHC because I went to Carolina, Tar Heels. So that's what I do. And I live, you know, in Tennessee volunteer country. It's kind of like not having an orange here. Your orange, I think, is nicer than the Tennessee volunteer orange, I will say. Ours is a little bit garish, but the blue is for BHC, and so that flow will happen in the exam room. You are just part of that flow. And these little things make a difference. That when you walk across and a patient sees, okay, the blue flag is out, and you're going, you know, your BHC is there, that's very different from pulling them into an office with the sofa. So what does our behavioral consultant do in primary care? People talk about the role of psychology. This is really a much broader set of skills and competencies. So we will address psychosocial aspects of acute and chronic diseases, diabetes management, hypertension. For whatever reason, recently we're having a lot of people come in with migraines, and so, you know, I've been working with a lot of people in terms of migraines and helping them with that. So again, it's using kind of the foundations of psychological theories and behavior change and what we know in health psychology and applying it to the primary care setting. And then certainly application of behavioral health change to health risk factors, and probably the most common is tobacco cessation. You know, smoking cessation is a huge issue, and then obesity, which is I know for several people it's a passion here, and it certainly is for us. You know, the food in Tennessee is not the healthiest, you know, so our patients show up and they've had their biscuits and red-eye gravy and, you know, more fat back for breakfast. So we've done several things to really target obesity. So if you are a child between the ages of 2 and 18 and you are seen in our system and your BMI is at the 85th percentile or higher, you will see a BHC. And then we will track your BMI, we track your health behavior change. And it's been very neat. We've been doing this for 4 or 5 years. I think we're in our 5th year now, and every year we've tracked a significant reduction in ZBMI. And, you know, we've, to be frank, focused on reducing sweetened beverage intake and decreasing screen time. So if you can do those 2 things, it's amazing the change that can happen, because our kids are just drinking soda all day and playing video games all day. So again, this is an example of you don't have to do a lot. You don't need the whole family in psychotherapy for months and months and months, but you do need to focus on, you have to do something, and you have to be very focused and targeted, and we've been able to identify consistently very positive clinical outcomes. So that's a neat thing that you get to do in primary care. And then certainly focusing on resiliency, that's a big buzzword for us these days, and patient activation and patient involvement. The patient is the most underutilized resource in healthcare. They really are. So getting them on board, getting them involved, and it really just starts with that culture. of just saying, look, we're going to do 100% of our part, but we need you to do 100% of your part. And then certainly the consultation and co-management of specialty mental health. So people always want to know, does this mean, are you still going to deal with depression and substance use? Yes, yes, yes. So think about what this means. If it shows up in primary care, a primary care psychologist should be able to see it. You cannot come in and say, I don't do substance abuse. I did talk to someone who said, I'll do all that stuff. I don't feel comfortable with substance abuse. If we could refer that out, that would be great. That does not work. Okay, if it shows up in primary care, you have to have some general working knowledge. And if you don't, learn about it. That's what primary care providers do. This is just an example. This is interesting. This is one of my afternoons. I taught an intern seminar in the morning, and I showed that slide, and they said, but how does this look? It was at the very beginning of the year. And so I tracked my patients for this afternoon. And as you can see, the first kid I saw was a 12-year-old boy with abdominal pain. He was a new consult, and he had been to the ER multiple times. With abdominal pain, which is a really common, my tummy hurts, right? It's a very common thing. But once you've had some workups, let's see what else is going on. And in fact, the parents were in the middle of a vitriolic divorce. I mean, and the only time that they would talk to each other and not fight is when he was sick. So boy, that kid was not going to get better. Right? What does it mean if you don't get better? So you can do as many scopes as you want, you can give as much medicine as you want, but we had to address it at that systems level. And when we were able to do that and bring the family in, the stomach pain got much better. This is where you have to be very directive, and luckily, I mean, both parents would show up and actually be cordial to each other when the doctor was around. So we took advantage of that. Then I moved, then you'll see move to male with chronic depression, diabetes, hypertension. That was a follow-up. Then a female with fibromyalgia and insomnia. So this is an example. Fibromyalgia, there is no cure. You could see them forever and ever. There is very little that's going to make them feel totally better. But what we can focus on is help you get a little bit of sleep, improve your sleep behavior so you can have a little bit better functioning. That's our goal. That's our goal. That's it. Because if I set a clinical goal like, I want you to globally feel better, I will fail. You have to understand what is the process going on here. And so you have to break things down to what is a functional goal. And this was very helpful. This is where we spent just as much time for the medical provider, because the medical provider is going crazy. Every time they saw this person, this woman, she said, every time I see her, I'm 45 minutes late. That's it. I tell my nurse, I don't want to see her in the morning because it makes me 45 minutes late. And neither of us leaves the session feeling good. Nobody leaves because she wants validation, and so I'm telling her this test is negative, and she should be relieved to know everything's negative, but then all she does is tell me how much she hurts and how she doesn't feel good. And I'm like, but this is negative. And she goes, and for her, that's like, boy, then you don't understand, so I'm going to up the ante. And then it sets up a really nasty cycle. So what we did with her is from now on, whenever she comes in, she sees the BHC first. We contain her, get her very focused, and then she can have a brief visit with the medical provider. And so as you can see, I'm not going to go through each one, but as you can see, this is a really interesting, varied day. This is what showed up in primary care. This is my schedule. The very last patient, 46-year-old female with grief. This is an example of where, why we need to have access early. Her son, the day before, was killed in a skateboarding accident. He wasn't wearing a helmet. And it was, it was all in the news, and she didn't know where to go. I mean, she was still in shock, and she just showed up at her primary care doctor's office. She just said, I don't know what to do. Now, to tell you the truth, if she had called community mental health or somebody asked to get an intake, they would have said, well, we can schedule you in 2 months. Frankly, even 2 days would have been too late. She needed it then and there. So when she showed up, frankly, a medical provider didn't even see her. When they said, she's like, I'm here because my son just died. They knew immediately, the nurse said, they don't even need to see the provider. They need to see you. So this just, again, gives you, I think, hopefully a flavor of what the model looks like on the ground. And then the continuum of integration is, I think, critical. And how this works with specialty mental health can sometimes be a challenge to show visually. And I wanted to have something that shows there's a bidirectional component and there's a continuous component. And I used to do a flow chart, but it's very hard because it's bidirectional. So when someone comes to consultation through primary care, we'll do an assessment and we'll do brief targeted interventions, but there may be some people who really need specialty mental health. So actually that woman who had been raped multiple times, she had very severe PTSD symptoms. And we knew very early on she needed to work with a psychologist in some pretty intensive psychotherapy to work through those issues. Brief work was not going to do it. And so then we were able to then link her with one of our specialty mental health therapists because it just didn't, not only, it just was even out of her realm and it just wasn't part of her language and she didn't think about it, but it was in the same clinic. And then at the same time, we were co-managing with primary care. So that doesn't mean just because they go to specialty mental health, there's no communication. And then what happened is she was better. Once she'd worked through these issues, then she came back and we reabsorbed her in primary care. And then I still see her periodically. She comes through primary care now maybe once a year. But once we got her kind of workup, she had her PAP, we did all our relaxation. She was in a place where she could do that and she had her coping skills. I still see her for monitoring once a year when she sees her medical provider. But what you can see is that reabsorption is key. So when you think about referring to the specialty mental health sector, you can't just think about one way. You have to think about it going the other way because every time you send someone there, you're clogging the system. It is an overburdened system. Anyone who go to community mental health, and if there's someone who says that they're not overwhelmed by the need, I would love to meet them. Please, I'd love to meet them and, like to hear what's going on in your community. What are you doing right that you're able to address all these issues? So you're going to have to reabsorb in primary care. So in fact, just this week I got a list of patients we have in our pediatric clinic, a pediatric BHC developmental psychology postdoc, and who specializes in autism spectrum disorders, and our child psychiatrist who's consulting. So what we got is a list of everybody who's being seen in specialty mental health and is also being seen in that pediatric clinic. And now what we basically did is told all the specialty mental health folks, go through this list. If there's anybody stable enough who can be reabsorbed in primary care, send them to us. Because when you send them to us, even if it's 15%, you've opened up access for people who need it the most. Okay, so you have to think about this as being a fluid system, and everybody's kind of needs to get involved with that. And this is going to be important because for mental health, it's really hard for people to say like, we've done some good work. Now let's see if you can be reabsorbed to kind of a less intensive level of care. So what does this mean for behaviorists is really different, isn't it? I mean, it's just a very different kind of practice. The pace is faster, the scheduling is different. The scheduling for primary care behaviorists is the same as primary care providers. We are scheduled, our templates look exactly the same. Primary care providers have slots for same day work-ins, right? And follow-ups, and we have the exact same. The communication, there's a lot more communication that goes on. Co-management is critical. The idea that this is not just your patient in your own silo, that you are always, this is our patient, you're co-managing everything you do. And when you think about a goal or an intervention, you have to think, how does this fit in with the overall plan that the medical provider has, and vice versa. The same with that level of coordination. And think about the kind of lifespan care, that once if someone is on your panel, you're there for them for the rest of their life and your life, that you're in that clinic. And that's different. There's not a stop and then a start and then a termination, as we talked about before. So the whole concept of confidentiality shifts because the informed consent for care is for the entire team. And we can certainly have discussions about, is there true confidentiality these days with the way things are, you know, with some of these health systems. But you have to really think broader in terms of when you're in primary care, there's a different level of understanding and informed consent that the patient has, and you have to educate the patient about that too. Documentation, as we talked about, needs to be different, and think about the population, not just the case. So these are some of the key pieces, I think, that are a real shift for people. And what does that mean? It means, boy, you have to get the right people on the bus. And not everyone can do this. I can tell you I have scars from, you know, and PTSD myself, I guess, from when we've hired some really great clinicians, but they just didn't fit, you know, with this whole thing. So for us, mission is everything. We want them to be mission-minded. What, you know, how can you be of service? Team-oriented, really have a commitment to excellence. Like, you know, being mediocre is not okay. We had a psychiatrist who interviewed with us, and he says, I tell my son every day, if I can come home and do a mediocre job, if I can be average, that's good by me. And that is just not going to work. He said that to us. And we're like, boy, we really need a psychiatrist, but that's really, you have to have a commitment. How can we do it better? How can we do it better? And that naturally means flexibility. You have to be able to communicate, and you have to value everyone. You know, we have a saying at Cherokee, nobody is special and everybody is special. You know, so you have to think about, value each person and really cherish and honor their contribution. And then everything you do has to be seen within the context of the broader picture. So if you choose to, you know, our clinicians have flexibility. If you choose to see this person for 2 hours a week for, you know, every week, that's fine, but you have to recognize who's not being seen and what's our population in that way. Here are the people who don't do well. They love solo practice. They love, you know, my turf. We get people come in and they say, I love, you know, my practice, my schedule, my people. People have said that. We had a therapist, we had a behaviorist we interviewed, and they say, you know, I just don't like to be interrupted. My door will be closed. I just don't want to abandon my patient, and so you can't interrupt me. And I'm happy to educate the primary care providers about that. So, no. My turf, narrow lens view, just thinking about me, my. So just watch out for that. It just doesn't work. Good luck to you if you think that way. Okay. Financing, I'm just going to speak very briefly. So everybody talks about money. Financing the behaviorally enhanced healthcare home, however hard you think it is, it's harder than that. Just understand and embrace that into your existence, because if you go into it thinking, I just need to find a way to make it easy, you will just be in a lot of pain. That's all I will say. It's just really hard because our financing system is fragmented. It is engineered around a pathology-based model. Fee-for-service is engineered, really, it promotes churning, it promotes siloed care. It does not promote any of those other goals that we talked about earlier. And so, you know, while we are seeing change, and, you know, Massachusetts is really avant-garde in this regard, in terms of looking at innovative models, just know it's going to be hard. And if you accept it and embrace it and bring it into your experience, you won't get as upset about it. Trust me, just kind of, you know, roll with the resistance, I would say. So these are all the disincentives. I don't need to tell you. You know, we all know nightmare stories about carve-outs, documentation requirements. I talked to some clinicians in a state where it was a minimum of a 3-hour intake they had to complete to get paid. The same-day billing prohibition, in this whole encounter-based thing. What if you only need one, you know, session or 3 sessions? To help someone, but you actually get paid more if you do it in 6 sessions or 8 sessions. You know, how is that going to improve care and reduce healthcare costs? And then the coding. This is really interesting. We had a meeting with one of our largest payers, and they brought in their actuaries and their coders. So imagine coders. I don't know if you all know any coders? They have these really big binders, and they come in with their big binders, and we're describing some things that we do, and they've opened their binders, and they're looking at the different codes, and they say, we don't don't have codes for what you do. And and they're right, that's a very interesting experience. Try doing that. There are not codes for a lot of what we do, and that's a problem. So here are the different ways we can think about paying for it. Fee for service. Our goal is to do, stay away from fee for service as much as we can. Case rate, capitation, blended capitation, having some shared savings, percent of premium, and probably what's going to end up happening is something new that no one's even thought of before. So I've got our CEO looking and nodding, right? We probably haven't discussed, probably haven't found out what will end up paying for this, but what I can tell you is it will probably not be fee for service, and it won't have what we have now. So then what do we do when we're having this dialogue? We really think in terms of value. So I'm just going to give you an example of how it works and how it's worked for us. So this is distribution of resources in TennCare, which is our Medicaid program. So, everything Tennessee, they said they could do it better. So they took, they've got Medicaid money. They said they could do it better, and within, I think, 5 years went bankrupt and are still, struggling financially. But when you look at where the costs are getting distributed, where's the money going? It's specialty mental health. Look at that. How much is being spent on that? How much is being spent in emergency room visits and in inpatient costs? So that's really eating up a chunk of the budget. Mental health outpatient is only 4%, right? So if you look at the expenditures, this is what they're spending money on. So we are not going to go to them and say, well, just spend more on mental health because it's only 4%. We go to them and say, we can make your specialty service costs go down, we can make your inpatient service costs go down, and we can make your ER costs go down. So our goal is really medical cost offset. And so help us track this. And so they did. This is our utilization. This interesting. This slide is based on data that's several years old, but we just got updated data a few years ago. And this is one of our largest payers, and this is the payer with the largest penetration in our state. And so what do we see? You see our patients have a third of the ER visits. Then they compared us to every one of their providers across the state. Cherokee patients have 1/3 of the ER visits. So where's Dr. Velez? Because we talked about this yesterday at dinner. A third of that cost, 2/3 of the specialty costs, less hospital care costs. So a Cherokee patient costs 2/3 less than anybody else. And you do see a bump in primary care, but that's what they want. They want more people to be seen in primary care. So this data we've seen repeated again this past year. This is psychiatric. Those are medical costs. It's like psychiatric. This compares us to every other region in the state in terms of our mental health patients. And it's interesting that our average, so the East Tennessee has the largest average in terms of percentage, but for our patients it's still much lower. So what we're doing basically is we're not just saying pay us more to pay us more, we're saying pay us in a global way so we can be flexible and do what we need to do to help you save those costs. So again, think about the value added, not just pay us more. So that's, again, helps make things a little bit more broader. These are just some of our lessons learned. I've tried to embed snippets of them. I'm just saying define the mission of your integration and philosophy for everybody. Bring everybody in. This will fall apart at your front desk staff level. It has and it can. And in fact, we at Cherokee now, we're just meeting, we're going to revamp our entire orientation process. Our clinical directors, my goal is to meet with every new hire and go over our model of care with them. And it's going to take time, but it's going to be worth it. And then build your right team. You all know, anything successful that you've done, my bet is because you got the right people on board, right? So this integration is no different. What I want to do is just leave you with a couple of resources. We have the AHRQ has a site. that has a tremendous number of resources. It's integrationacademy.ahrq.gov. Sandy Blunt and I are on that advisory council, so that's a great website to go for resources. And I also want to give a plug for the Collaborative Family Healthcare Association, and Sandy was one of the founders. You know, the first time I saw Sandy, now I have to tell, I don't want to embarrass you too much, but I'd read his book. I carried Sandy's book around. I was a circuit riding BHC 12 years ago, and I carried his book around from clinic to clinic, and I still think it's one of the best books on integrated primary care. So I would carry it around, and when I went to CFHA and I saw him, I thought I had seen Mick Jagger, you know? I was like, oh my gosh, that's a lot. Like, so it was a gift. So this is the conference to go to, I think, in terms of learning more about integration. Cindy has gone. She's brought her team. It's going to bring more people there. It's in DC this year, and I really do hope you take time to check out the website, become a member, just be part of this group, be part of this network, be part of this community of people who are really committed to this very important concept in healthcare. So thank you, and do I have time for questions, or should we just leave it later?
That was a great presentation.
Thank you.
And you guys run one of the best organizations in the country. So congratulations on that. Could you say a little bit more about some of the funding challenges you've had? I mean, you outlined, and certainly all of those things are relevant,
yes,
including the code book. But how, you mentioned earlier that you lost a lot of money to begin with. How did you come back from that? And how do you work it now so that financially you're viable? Yeah, it is a daily fight. I would be lying to say we've had it fixed or we've worked it out. It is a daily fight. And so what's interesting, and it's interesting you're asking this question. You know, I was in a meeting recently with a very large national payer, and it's really hard for them. It's really hard. Everything is a struggle because they are under their own pressures. And so when I say, when you say the funding challenges, I will say that there are so many, I can't even count them. And what you will find is it's like the, that game babies play where you get that little hammer and you push down one thing, it all pops up, and as soon as you push down one. So for example, it took us, it was a fight to get the 96150, the health and behavior codes, approved to be funded. Once those got approved, we had the same-day billing fight, where you can do it, but you have to do it on a different day. And are you kidding? With our patients say, yes, I need to do some self-management for diabetes for you, but you have to come back tomorrow. I can't do it today. We were not going to do that. So then we fought that battle. Then, this was a brilliant battle. They said, yes, we will pay, but they did not credential any of our behaviorists. The MCOs did not credential any of our behaviorists because they said, we don't know how to credential behaviorists. There was all the carve-outs, right? So the BHO, the behavioral health companies had their credentialing, and the MCOs had their credentialing, and they never spoke to each other. And so our psychologists and clinical social workers who were billing these codes, the codes would go to the medical part, right? And they would say, well, they're not credentialed. Well, can you credential them? Well, we don't know how to credential behavioral health. Well, can we show you? Well, we don't really have a system for that. So I would say you have to be very determined, and you do. You just have to say, all right, fine, we'll help you, we'll do it. So it takes constant vigilance. What I will tell you now is, now more than ever, there is openness for everyone in terms of flexibility. The conversations we're having now with payers, they want to really collaborate. And I think it's because they recognize something's going to have to change. So I will say now is really the time, and now is the time to jump on it. And I've heard payers say, we try to talk to providers, but they want to do it a certain way. And so I think our providers need to get on the game and say, you know what, we need to think more about providing value than just churning in fee-for-service. So I think everybody's going to have to come to the table with some goals, shared goals, and we're all going to have to give a little bit. Yeah. Tavia.
Parinda, Really love the get on the bus or get off the bus if you don't have the right tools and the skill sets. But that makes me think that one of the rate limiting factors out there is obviously the workforce.
Yes.
Can you address how you've been able to find the right people?
Yes.
Because I know I've had a few calls just within the last few months here in Texas looking for individuals with these skill sets.
Yeah, it's
people
really
are
hard.
hungry for them out there. So I'm wondering, do you develop any internal development
Yes.
mechanisms you've
Yes.
developed?
Yes. Yeah, so it's very hard to get the right people. And then, you know, to me, personality and characteristics are really the harder things to change. You know, you can teach skill sets. So here's what we did. We started our own psychology internship program. That was the main goal, is like we had no BHCs. So we started it, and that has been a huge driver for us. We have a postdoc. Now there are more and more training programs. Sandy has an excellent, what I think is really the preeminent certification program, and that is that flyer's in your packet. We've started doing external training as well, and I think that complements what Sandy does very well. He has a certificate program, and people can come to our site and train. So I think that what we've had to do is get involved in training. I think it's really hard. It's hard to just expect someone to fall into your lap, but I think if you can engage and invest in training across the board, that's the only way it's going to happen. I think that long term, the kinds of things that Cindy's doing, the kinds of things that we're seeing a real change at the graduate level, that's going to create a groundswell of new folks who can do it. But we have an existing workforce that needs to be retrained, and I think we need to kind of really build a community and build an infrastructure for that.
I'm next over here.
Where are you? Oh, hey,
yeah. Thanks for a very engaging presentation. My question is about one of the early slides, and you mentioned telehealth.
Yes.
And here in Texas, for example, we have, thousands of square miles where there are no providers.
I know.
And so on. And I'm wondering what your experience has been with that, and what kind of complications you've encountered. In APA, there's a lot of talk about HIPAA problems with.
Yeah, we've been doing this for 14 years, and when we first did it, it was with psychiatry. And those of you who remember Max Headroom, do you remember that? It was like that. The technology was terrible and everything. Now we only use secure T1 lines. So with all our providers who work at home, we build our own connection. Everything is secure. We have a nurse on the other end. And it's just like a visit, but we have to have those precautions. And I think the thing is, when people have done it and they try to use Skype, or they try to do it without a license, someone on the other end, I don't think it works. It ends up being very clunky. So we've been very strict about the quality and really utilizing kind of the best technology that we can. Now we're actually looking at iPads. We've got our case managers with iPads going under bridges and going out to our community members and beaming in. But in this day and age, frankly, with everybody they're just so used to seeing screens that we've not had any problems in terms of patients, at all. They just seem to accept it, and it's a normal thing. And it's been wonderful. I mean, to be honest, I don't think we have any child psychiatrists who are only at one site. I think that's so hard to get. Our child psychiatrists are beaming. We've got some that beam into like 4 different sites, and you just have to have a trained person on the other side and have certain protocols in place. We've got a protocol for if the person on the other side mentions the weather, we know that person smells like some serious alcohol, right, is there. You can't smell. So you have to have certain things that you say, and you do. But we've had to really develop pretty strict protocols, but it's been very successful. And frankly, we couldn't function without it. Our psychiatrist service, some of our best primary care, we just couldn't function without it. A lot of our school-based stuff would shut down if we didn't have it. I think it's a great way of providing access to care. But do it right. Don't use Skype, and don't just use anything open. Get very secure lines, invest in the technology, and invest in having a trained person on the other end.
I'd like to expand on that question and see if you know the difference between the telemedicine or the telehealth standards in your state versus Texas, because my understanding here is you made mention of going under bridges and doing the context of which we're trying to do, but it's not a site that's considered a medical site, so we're not able to bill for those services. Is it different, and how did you get that to be different?
Yeah. No. But we don't do that for a medical service. We don't do that for a medical service. For the medical service, it's going to have to be at a site. So going under the bridge, that's really for our care coordination and case management outreach. If we have a clinician involved, that's typically not going to be something that we bill. It's really trying to bring someone in. But we can't provide clinical care in that kind of, that's not a private setting. But, we need to bring people in, and we need to get them engaged in care coordination and basic goals, and that's what we use that for. Otherwise, everybody else, comes to the clinic, or there's or the school.
So
Thanks.
One more question. I'm sorry. I'm very interested in telehealth. We have a telehealth program, and we're just launching in that area. And so we're doing some school-based services as well. But would the nurses station or a similar situation in a school could possibly be eligible for that billable site?
Yeah, we bill for all our school stuff. So basically what we did is we have people at every school. So we have actually, a couple of pediatric nurse practitioners that beam into 17 schools in Sevier County, where it's all the Smoky Mountains. So it's, forever to go there. But what they do is at the beginning of the year, we explain it, the parents get an informed consent, we collect their insurance information, we get all of that. So we're able to bill for those services. And it's just acute care. Like, we're not providing complex care, but we follow certain protocols. But frankly, that's the needed for the kids, is a lot of it is acute care. Yeah. And they will tell you, our providers will tell you, they can see much better with that equipment. The otoscope, everything has, a camera in it. You can magnify, you can look down the throat, and you can freeze it. I mean, it's better, they'll say, if I have to see a person live, I can't see that well, and I can't get their tongue down that far for that long, but they can take pictures, they can hear. It's all very, very, it's been a wonderful way. It's a wonderful way. The technology has been just fantastic, yeah. But you can bill for that.
So I just want to echo what everyone said, and thank you for that really informative presentation.
Thank you.
And I'm wondering if you might be able to speak to the graduate students in the room. I know my ears perked up when you said that there were a number of things you wished you had done in graduate school to kind of educate yourself about the financial aspect of this work. And so I'm wondering if you have any recommendations for us.
You know what? I would just read and be informed and be involved in kind of what is the broader healthcare climate. So you understand the language, you understand the all the factors that are at play. So I think in terms of advocacy and policy, you need to know that. And I just didn't know that. I just thought when I was in grad school, you just go in that if you do really good work, it'll be fine. You just need to focus on doing good work. And the thing is, you certainly need to do good work, but you need to understand that psychological practice or research takes place in a broader context. And we can't just be passive recipients of that. We need to be active and engaged. So I would get involved. I'd get involved, read, learn, go to all the different town meetings. I'd get involved with, the local, your state psychological association, the state primary care association, but kind of be in the know, because that's the only way you're going to affect change. There's a saying we have, our CEO always says, if you want to predict the future, you need to create it. So make what you want, and you can only do that by being in the game.
Other questions? Not. Thank you.
Great. Thank
so
you.
very much.
Thank you.